Okay, so I want to start by letting everyone know that this presentation has a lot of medications on it. And if you try to memorize it like slide by slide or name by name, you will get overwhelmed. Um, so before we even look like into any single drug, I want you, I want to give you one idea that will make this entire class make sense. So every single medication that we talk about today does one of two things. So it either kills an abnormal cell or it changes how loud or how quiet the immune system is being. So that's it. It either kills a bad cell or it turns the immune system sort of up or down. So then as we go through the oncology drugs, the HIV drugs, um, the biologic response modifiers, antirheumatics, and the immunosuppressants, I want you to constantly ask yourself, which of those two things is this drug doing? And if you can answer that question for any medication on this deck, then you already understand it at the level that's important for this assessment. And so then we will finish the presentation doing some dosage calculation built specifically around this content. So we will be talking about body surface area. Um, Body surface area dosing is how some of these medications are dosed, some of the oncology medications and the immunosuppressant medications, which I know is a new concept. So don't worry, like we will get into that when we get to that point of the presentation. So these are our learning outcomes. And then every drug class, and when we say drug or medication, right, we're using that term interchangeably. So they basically mean the same thing. Drug, medication, same, okay? So every drug class that we cover, we will basically go through the same kind of 6 questions. What is it? What does it do? When do you use it? When do you avoid it? What does it interact with? What does it hurt? And then what can you teach your patient? So here's my advice. Don't take notes trying to capture every word I say. Instead, use those 6 categories that I just said as your note-taking template for every single medication that we go over today. So we'll have the prototype, the mechanism, the indication, the contraindication, the interaction, the effect, and then the education. So if your notes have those kind of 7 headers repeated for every section that we go over, then you will be taking the right kind of notes. And so then the other 3 outcomes are really just application of that same framework. So comparing the drugs to each other and then doing the math to, make sure we're dosing safely for our patients. So let's start with some foundations with cancer and the reproductive cycle of a cell. So before we get into any like specific medication names, what actually is cancer at the level of a single cell? So a normal cell doesn't divide whenever it feels like it, right? It moves through a cycle. And at several points in the cycle, there are like checkpoints, basically like little security guards that check the DNA and then ask, is the cell healthy enough to keep going? If the answer is no, then the cycle stops and the cell is told to self-destruct. So cancer is what happens when a cell finds a way to sneak past those security guards and it just keeps dividing over and over, ignoring every sort of checkpoint as it's going through the cycle. So this slide sort of walks us through the 4 active phases, G1, S, G2, and M, plus a resting phase that's called G0. So you can see the definitions here. I'm not going to read those definitions to you, but what I want you to actually understand is why we care about this cycle in a pharmacology class. So chemo medications fall into two sort of big camps based on this cycle. So some medications, we call them cell cycle specific, and those only work if they catch the cell during one particular phase. So think of it sort of like a security camera that only records footage from 2 and 3 p.m. If the crime happens at a different time, then the camera is not going to catch that, right? So that's how cell cycle specific medications work. They only work on a specific cycle of the cell. And then you have other medications that are cell cycle non-specific. And these medications don't care what phase the cell is in. They will hit whenever they encounter it. So the single idea I want you to take away from this slide is it's going to explain nearly every side effect you learn for the rest of this section. So chemo can't read, right, a name tag. It can't tell a cancer cell from a normal cell that just happens to be dividing quickly. So cancer cells are cells that rapidly divide. They've somehow sneaked past the checkpoints that they're supposed to go through, and they are rapidly dividing. Now, there are good cells also that follow the same pathway, that they rapidly divide. So with that, so like your bone marrow, the lining of your GI tract, and your hair follicles, those are good cells that rapidly divide. But chemotherapy doesn't know the difference between a good rapidly dividing cell or a cancerous rapidly dividing cell. So when these medications are given, they are just attacking those rapidly dividing cells. And unfortunately, the good cells become sort of like the innocent bystanders. So that's why almost every chemo drug causes some combination of like a low blood count, because your bone marrow is rapidly dividing. So when you take this chemotherapy, it's attacking those good cells as well, and that causes a decrease in your bone marrow function, which causes a decrease in your blood counts. GI upset or mouth sores, because the lining of your GI tract is rapidly dividing. So the chemo can't distinguish between, is this good or is this cancer? So it attacks it as well. So then you have GI upset, right? You have the nausea, the vomiting. You have the sores in your mouth. You have the sores in your stomach lining, the mucositis, the what am I trying to say? The stomatitis. Those are like the sores that you get in your mouth, and the sores, I'm sorry, that you get in your stomach, in your GI tract, essentially ulcers. And then you have hair loss, because the hair follicles are also rapidly dividing. So those get caught up as innocent bystanders as well. And so then when those rapidly dividing cells are attacked, that's why hair loss is a side effect of chemotherapy. So you're going to hear myelosuppression several times as we go through this presentation. And that's basically like the major side effect, right? That's the bone marrow suppression, the function of the bone marrow happening basically from many of these cancer medications. So this slide lists all 6 sections that we will be covering. So I don't need to read this list to you. You can see it. What I want to do instead is give you a way to organize it in your head, because on its own, it can sort of feel like 6 unrelated topics. So we want to sort of group them like this. The first 5 sections are all about managing a disease that already exists in the body, a tumor, a virus, an autoimmune response, even a transplant. And then the 6th section that we will cover are vaccines. And that's sort of like the odd man out because it's the only section that talks about preventing a disease that hasn't happened yet. And so within those first 5, you want to ask yourself, is this medication attacking a human cell directly? Is it attacking a virus? Or is it adjusting the immune system? So oncology attacks a human cell. HIV therapy attacks a virus. And then the last 3, the biologic response modifiers, the antirheumatics, and immunosuppressants, those are all immune system sort of dial turning, just in different directions for different reasons. So just kind of keep that mental map running in the background, and it'll help you sort of place each new medication into a bucket instead of trying to like memorize 42 isolated facts. All right, so let's start with oncology. And there are 9 medication classes that are coming up. And I promise it feels a lot less once you see the pattern repeat. But every single one of these 9 slides is going to answer the same 6 questions we just talked about. So rather than me reading each slide's bullet points, top to bottom, I'm going to spend, time on the parts that actually are hard, the mechanism, and then why it matters clinically. And then the dose specifics and full lists are already right there in front of you for you to be able to read. So the anti-metabolites are the first class of medications that we will discuss. Now, before we jump into these, I just want to point out that we do discuss a lot of medications here, but a lot of these medications are very hard to pronounce. So rather than stumbling over my words trying to pronounce them, I'm not. If I know how to pronounce them, I will. If I don't, I will just direct you to the top of the slide where it lists the prototype medications. Okay, so back to anti-metabolites. And there are 3 prototype medications for anti-metabolites. These are methotrexate, cytarabine, and mercaptopurine. And so here's the trick to understanding all 3 of these medications without memorizing them separately. So you want to, when you're thinking of a cell building DNA, you think of that like building a brick wall, right? So you need specific bricks to build a brick wall. So the same with the cell building DNA. It needs specific bricks, or it needs specific compounds in order to build the DNA inside of the cell. It needs folic acid, it needs pyrimidines, and it needs purines. So anti-metabolites are sort of counterfeit, bricks that are needed. So they are shaped just enough like the real thing that the cell's machinery grabs a hold of them and tries to bring them inside for that DNA synthesis. But it essentially falls apart because it's not really folic acid, right? It's a fake brick that gets in there and it stops the synthesis right there inside of the cell. So methotrexate impersonates folic acid. Cytarabine impersonates a pyrimidine, and then the mercaptopurine impersonates a purine. So same trick, just basically 3 different disguises. So the cell needs these specific compounds in order to build DNA within the cell. It needs folic acid. So when a patient takes methotrexate, The cell sees that methotrexate and it thinks it's folic acid because it's designed to look like folic acid. And folic acid is needed for DNA synthesis. So the cell grabs a hold of that methotrexate, takes it inside of the cell to try to use it as folic acid to build the DNA. Because it's not really folic acid, the DNA does not synthesize. So it stops right there inside of the cell, and it stops that cell from being able to go through the S phase of the cycle. So because it happens specifically at the S phase, these antimetabolites are considered cell cycle specific medications. Now, I want you to notice methotrexate because methotrexate is used in very high doses to treat cancer. But when we drop that dose significantly, it's also used later when we discuss the anti-rheumatic medications because methotrexate in very lower doses is used to treat rheumatoid arthritis. But we will get to that later when we're discussing those medications. So I'm not going to walk through every contraindication or interaction bullet on the slide. They're right there. And honestly, most of them follow logically once you know the mechanism. So ask yourself, this medication suppresses bone marrow and it's teratogenic. So what would you expect to be contraindicated? So do you know what teratogenic means? So teratogenic means that it's toxic to a fetus or right the baby growing inside the mom's belly. So if you have a teratogenic medication, are you going to prescribe this to a patient who is pregnant? Probably not, right? We are not trying to do any harm to the baby that's growing inside of the mom. So this class of medications is not prescribed to pregnant moms. And also, if it's going to suppress the bone marrow, then it makes sense that we are not going to prescribe this medication to patients who have existing blood disorders, right? Because if it's going to suppress your bone marrow, it's going to suppress the function of your bone marrow, then your blood count is already going to be low. So if you have an existing blood disorder, and then we're going to give you a medication that's going to further add to that, we're not going to do it. And then we also don't prescribe this medication for active infections, right? This is going to come in. It can't distinguish between good cells and bad cells. So if your patient is already fighting off an infection, the immune system is already trying to fight off whatever is causing the infection. We're not going to throw something in there that's going to sort of wipe away whatever defense they already have or they have left from trying to fight off an active infection. So, two things I do want to just make sure to touch on. First, NSAIDs and aspirins reduce methotrexate's renal clearance. Meaning that the kidney can't get rid of it fast enough. So then it builds up and becomes more toxic, right? Because we know that medications are excreted in the kidneys. So if your patient is also taking an NSAID or an aspirin, it's going to reduce the ability for that methotrexate to clear out of the kidneys, to be excreted through the kidneys. So then it's going to build up and it's going to become more toxic. So that's a real interaction that shows up constantly when you have patients who are on these medications because so many patients just reach for ibuprofen without thinking twice about it. So we want to make sure we are including this in our education to our patients who are taking methotrexate, that they should not be taking NSAIDs and aspirins. Reach for the Tylenol instead of reaching for the ibuprofen. And then second, After a high dose of methotrexate, patients get a rescue medication called leucovorin, and this medication is timed precisely. So leucovorin essentially replaces the folic acid that methotrexate blocked. And because it's timed to rescue healthy cells after like a tumor cell has already been hit. So getting the timing wrong, you either don't protect the patient, or it's undoing the chemo's effect entirely. So with this leucovorin medication, timing is not a suggestion here. It's the entire point of the medication. So if the patient is given a specific time of when to take this medication, or you are responsible for administering this medication for this patient, it is very time sensitive. It's precise, and you have to make sure you are doing it at that time. It is not a suggestion. It's not one of those medications that you can give, an hour before or an hour after as you're trying to, manage your time throughout your shift. That these are very time specific, and whatever time it says to give that medication, that is the time that you want to make sure you are giving that medication. Okay, so then we will move on to the alkylating agents. And there's a whole list of slides, I'm sorry, a whole list of names on this slide. And I don't want you to panic, just seeing like that whole list. Just know that these are the alkylating agents. And then we will talk about the mechanism, because that's what actually organizes the list for you. So remember, the anti-metabolites were like the counterfeit bricks. Think of the alkylating agents more of like a super glue. So they physically weld like the two strands of the DNA double helix together. So once that's done, the cell literally cannot pull its own DNA apart to copy it or read it. So then that's it. Game over for that cell. Because gluing DNA together doesn't require the cell to be in any particular phase, you can glue it wherever, whether it's resting or actively dividing. These cells, or I'm sorry, these medications, the alkylating agents, are cell cycle non-specific. And that's a direct contrast to what we just covered. And it's a favorite. Compare these two classes on like an assessment kind of question. Now, cyclophosphamide is worth a special mention because it sort of moonlights. So later in this class, we will discuss how we will discuss this medication again in the immunosuppressant section. And it's used to sort of like calm an overactive immune system with autoimmune diseases. So it has the same sort of superglue mechanism. Um, DNA cross-linking hits rapidly dividing immune cells too, not just cancer cells. So I want to spend our real time on the adverse effects, because two of them have very specific antidotes, and those are usually testable. So cyclophosphamide and ifosfamide are notorious for hemorrhagic cystitis. It's ifosfamide. I think I added an extra syllable in there. It's cyclophosphamide and ifosfamide. But these two cause the hemorrhagic cystitis, which is bleeding and inflammation in the bladder. Because a toxic breakdown product sits in the bladder and irritates it. So to fix this, there's a medication prescribed. It's called Mesna. And this is, again, one of those medications that are given on a strict schedule. And then we also educate our patients to drink lots of water, drink lots of fluids, to frequently flush out that bladder. So we want them voiding frequently so that they are flushing out this toxic medication and it's not sitting in the bladder causing this hemorrhagic cystitis or the bleeding and the inflammation. And then cisplantin is the other one to know. This one is highly emetogenic, and that means it will cause your patient to be nauseous and vomit. So patients need an antiemetic before starting this medication. This medication also, cisplantin, it's hard on the kidneys and the ears. So you will expect nephrotoxicity and ototoxicity. So audiology and renal functions are closely monitored when patients are on this medication. So if a patient on cisplantin tells you that they are having ringing in their ears, that's not a random complaint. That's the drug doing exactly what it's known to do. Okay, moving right along to the anti-tumor antibiotics. These are also called anthracyclines. And doxorubicin is the prototype medication. So this is a medication I want you to remember by its nickname on the floor, like on the unit. It's called the Red Devil, and you'll hear it called that in clinical. And I'm going to just explain why. So mechanism-wise, doxorubicin is basically doing three different kinds of damage to DNA at once. It's wedging into the strand. It's blocking an enzyme the DNA needs to uncoil, and then it's throwing off free radicals for extra damage. So you don't need to memorize all three separately. Just know it's a multi-pronged attack, and it's cell cycle non-specific. So it's same as the alkylating agents, in a sense. So here's the part I want you to walk away understanding and not just memorizing. Doxorubicin carries a boxed warning for cardiotoxicity, and the danger is cumulative. So it's not about any single dose being dangerous, it's the running lifetime total. So just sort of picture a bank account of heart damage that never resets. Every dose makes a withdrawal, and then once you hit the limit, that's it. No more doxorubicin, ever, for that patient, regardless of how well the cancer is responding. So that's why you'll see providers tracking lifetime cumulative doses like it's a hard ceiling, because it is. So two more things to know. This medication, doxorubicin, it is a vesicant, and that means if it leaks out of the vein, it causes serious tissue damage. So burning or pain at the IV site, we call the provider right away. That's a call the provider right now situation, not a wait and see. So with this medication, when we are administering it intravenously, we insert, I mean, most of the time what's going to happen is your patients who are receiving any form of chemotherapy, they usually have a port or a central line or some sort of, like large bore IV that's going to make sure it doesn't leak out of the vein. However, if we start this medication, on our oncology unit at the hospital, or your patient, gets to their treatment center and an IV has to be started, we're making sure to start a large bore IV, right? We're not putting a 22 gauge in this patient and thinking we're going to infuse doxorubicin. Not ever. So you want to go with a large bore IV. You want an 18 gauge or larger. but technically smaller when you're thinking about how the IV gauge works. So you want an 18 gauge, a 16 gauge, a 14 gauge. You want something huge that this medication is going to be able to travel through, because you don't want to take any risk of this medication like the coming outside of the vein and leaking into the tissue, because it is a vesicant and it will cause serious tissue damage. And then also with this medication, it turns the urine sort of a reddish, orangish color for a day or two after. So we make sure that we educate our patients. This is expected. We educate that this is expected. It is not blood. And if you don't warn them ahead of time, they will be afraid. They will stress out. They will think that they are bleeding, and they will call the physician, or they will call, back to the unit that they were treated. So just make sure we are explaining that this is expected for a day or two after this medication. Okay, the mitotic inhibitors. So this slide covers two related groups, and these are the vinca alkaloids, so the vincristine and the vinblastine, and then you have the taxane paclitaxel. Different chemical families, but basically like the same strategy. So when a cell divides, it builds a temporary internal scaffold, and that's called the mitotic spindle. And that physically pulls the chromosomes apart into two new cells. So both of these medication groups basically sabotage that scaffold. So the vinca alkaloids prevent it from ever forming, and then the paclitaxel actually freezes it once it's built, so it can't be taken back apart. So either way, the cell gets stuck mid-division and can't finish. So because that scaffold only exists during mitosis, these are cell specific for the M phase, which is why they're called mitotic inhibitors. So the adverse effect I want you to really lock in on is the peripheral neuropathy with the vincristine. And that's, numbness and tingling in the hands and the feet. So here's a connection that makes it all click. The same microtubules that build the mitotic spindle also make up the structure inside your nerve cell. So a drug that disrupts microtubules doesn't just stop tumor cells from dividing, it can also disrupt how nerves function. That's not a coincidence. It's the same mechanism showing up in a different tissue. So here's a detail that's easy to miss, but typically does show up in practice constantly. Vincristine can cause severe constipation because those same disrupted microtubules affect the nerves that control gut motility. So proactive stool softeners often get started before the patient even complains of constipation. So that's a good nursing anticipation. It's not just overkill. Okay, so the topoisomerase inhibitors. Topotecan is the prototype medication. So DNA has to unwind like a zipper before it can be copied. And an enzyme called topoisomerase 1 is what does that unwinding. So topotecan blocks that enzyme, so the DNA ends up with breaks it can't repair. So that means the replication stops. So that only matters while DNA is actively being copied. So same pattern as before. This is cell cycle specific on the S phase. So the one thing to really flag on this slide, topotecan causes some of the deepest myelosuppression of any medication in this entire unit, especially neutropenia, sorry. So when your patients are on this medication, CBCs get checked before every single cycle. And then fever in a patient on topotecan is treated basically as an emergency. It's not a let's wait and see, because it has the deepest bone marrow suppression, right, of that function. So we can't do anything that's going to introduce infection or introduce something to this patient, because their bone marrow is completely suppressed here. And so that's what neutropenia means. Like, your patient will be on neutropenic precautions. So you won't see things like fresh fruits, fresh flowers brought into these patients. And then any sign of a fever, we treat that like an emergency and we immediately intervene. So now let's shift gears completely. So everything up to this point has been cytotoxic, which means it kills the cells directly. So hormonal therapy doesn't kill anything. It starves a tumor of the hormone that feeds its growth. So there are two strategies. Mhm. And just understand the difference conceptually versus just sort of memorizing what's happening here. So the medication class, like the SERMs of this group, the SERMs, the SERMs, the tamoxifen sort of medications, those go straight to the breast tissue and block the estrogen receptor itself. So sort of think of it like changing the locks on a door. Estrogen shows up, but its key doesn't fit anymore. And then the aromatase inhibitors, those sort of work upstream. They block the enzyme that manufactures estrogen, out in like the peripheral tissue in the first place. So instead of like changing the locks, it's like shutting down the estrogen factory altogether. So looking at the slide, right, the contraindication. So the aromatase inhibitors are contraindicated in pre-menopausal women. So if we just sit and think about that for a second, why are aromatase inhibitors only used in post-menopausal women? So let's think about where estrogen comes from before versus after menopause. So before menopause, the ovaries are the main estrogen source, and there's no drug can shut that down. After menopause, the ovaries have mostly stopped. So that peripheral conversion becomes the main remaining estrogen supply. And that's exactly the piece that this medication shuts off. So use of it, in premenopausal women, the ovaries are just going to keep making estrogen anyways. So one adverse effect, I want you to notice the pattern instead of memorizing two separate lists. So tamoxifen's biggest risks are things tied to estrogen still floating around, causing trouble elsewhere. So endometrial cancer, blood clots. The aromatase inhibitors, on the other hand, those remove estrogen almost entirely. Um, and estrogen happens to protect bone density. So their signature risk is bone loss. Same hormone, like opposite problem. depending on whether you're blocking the receptor or wiping out the hormone altogether. So, still on hormonal therapy, but now with prostate cancer. So, same concept as the last slide, different hormone, different sex specific cancer. So, prostate cancer is often testosterone driven. So, the strategy is to cut off testosterone supply or the access to its receptors. So, Leuprolide has a genuinely counterintuitive mechanism. So, it's a like a GnRH agonist. Um, and you think agonist means stimulate, and it does at first. It actually causes an initial surge of testosterone before the pituitary gland gets overwhelmed and shuts down testosterone production for the long haul. So it gets worse before it gets better, mechanistically. So that surge has real consequences clinically. And it's probably the single most important concept on this slide, and that's the flare phenomenon. So, in the first 1 to 2 weeks of the Leuprolide, a patient's tumor symptoms can actually get worse. More bone pain, more urinary trouble. Because of that testosterone surge, it's feeding the tumor briefly before the suppression actually kicks in. So this is why androgen receptor blockers are often started at the same time as Leuprolide, because they block the receptors from responding to that initial surge, and blunting that flare. So if a patient isn't aware that this is coming, they are going to think that the treatment is failing. And it's not, right? Like it at that exact moment, it's actually starting to work. So that's a major teaching point that we want to educate our patients who are taking this hormonal therapy for prostate cancer. The way that the medication works is that it causes that initial surge of testosterone before the pituitary gland gets overstimulated and shuts down the production. So, because of that surge feeding the tumor, they will see an increase in those symptoms, and then they will see a decrease. So, good education, good patient education is important with this medication so that patients don't get overwhelmed or stressed out thinking that the medication isn't working. It's doing exactly what it's supposed to do. So we will move into the monoclonal antibodies, and these are the targeted therapies. So the trastuzumab is genuinely a different kind of medication from everything we've covered so far. So I want you to just notice that shift. Everything before has sort of attacked any rapidly dividing cells, whether cancerous or not. Trastuzumab attacks one specific target. A receptor cell called, or a receptor called HER2 that's overexpressed on some, not all breast cancer cells. So HER2 is overexpressed on some breast cancer cells. So this is precision targeting instead of like a blunt instrument. And it sort of comes with a condition. So HER2 testing has to confirm that the tumor actually has that receptor before this medication is even started. So give it to a HER2 negative tumor and there's nothing there for it to grab onto. Like it simply wouldn't work. So the adverse effect to know for this medication is cardiotoxicity, and it is a boxed warning. Um, so you would notice a drop in the patient's ejection fraction, which indicates potential heart failure. So a clearly important overlap with trastuzumab and doxorubicin, that red devil from a couple slides ago, they're both cardiotoxic. So giving them together compounds that risk. So a lot of chemotherapy treatments are compound medications where you're giving two medications at once. So it's important to know that the trastuzumab and the doxorubicin, those are both cardiotoxic medications. So if these two medications are given together, it does compound that cardiotoxic risk. So that's exactly why oncology regimens are so careful about sequencing, and spacing those two medications out. So for these patients, we do a baseline and a repeat echocardiogram. And those are the safety nets here as we are monitoring the cardiac function of these patients. So you're wanting to make sure you're watching that ejection fraction number over time, and not just reacting after a patient already has a symptom. So still talking about targeted therapy, the tyrosine kinase inhibitors. Um, so the prototype medication here is imatinib, and there's a backstory with this medication, and it may help understand and make the mechanism stick for you. So in chronic myeloid leukemia, that's a specific genetic glitch. It's like the Philadelphia chromosome. It produces an abnormal enzyme called the BCR-ABL, and that basically screams grow, grow, grow at the cell nonstop. So the imetinib is essentially an on-off switch for that one specific enzyme. So it doesn't attack DNA at all. It just shuts off a single broken signal at the source. So this medication is often cited as one of the first real successes of precision oncology. And it shows in the side effect profile. Compared to everything else we've covered today, this medication is relatively gentle. It does cause fluid retention, GI upset, and it does have some liver and kind of bone marrow effects, but nowhere near the cytotoxic level of the drugs that we discussed earlier. So the teaching point I'd actually spend the most time on with a patient is that this is a daily oral pill. It's taken indefinitely. Adherence to this medication is everything. So missed doses, you're not just risking a bad week. You're giving the leukemia room to develop resistance to this drug permanently. So it's not just a medication that you can catch up on later. So some medications, even like antibiotics, but even you take a medication and you miss your next dose and you're just okay, I can catch back up as I take the next dose and repeat it. With this medication, missing a dose is risking a bad week. You're giving the leukemia that amount of space to just continue, and then that's what creates resistance to these medications. So having that mentality, it's just a pill, I'll catch up later, is exactly the mindset that you have to counter when you are educating these patients. It's not just a pill that they can catch up on later. This is a medication that they want to make sure that they are taking every single day, every single time. So take a moment to just actually look at this table. I'm not going to read it to you row by row because there's no value in that. You can read it on your own. But just look at certain like key adverse, like look at the key adverse column and notice that the first 5 rows, the cytotoxic medications, they all share some version of myelosuppression. And then the last 3 rows, the hormonal therapy, the monoclonal antibodies, and the tyrosine kinase inhibitors, those each have their own unique signature toxicity. So clotting risks, heart damage, fluid retention. So that split tells you something real about how oncology has evolved. So the older cytotoxic medications hit anything that divides fast. So they all converge on the same bone marrow problem. The newer targeted medications hit one specific pathway, so their toxicities are much more specific to that one target. So if I had to boil like the entire oncology section down to a single nursing priority, and it's basically this: assume that myelosuppression will occur until proven otherwise. Um, and we build infection prevention into your plan of care almost for any patient that's on an active chemotherapy medication. Okay, so moving away from cancer and moving on to HIV, which is, a completely different fight. With cancer, it's an abnormal human cell, but with HIV, it's a virus that's living inside of the human cell. Um, so HIV's whole strategy is to basically infect and kill the CD4 T cell, which is the cell that, organizes the body's immune defense. Um, so HIV mutates extremely fast. So essentially, HIV is treated with combination therapy. There's not just like one single drug that you're going to use when you're attempting to treat HIV. And it's because I'm sorry, mutates extremely fast. So trying to hit it with just one medication, the way that it mutates so quickly, it's like one medication is not going to do anything for it. It may hit it at some point of its cycle of, continuing to mutate, but the chances of that happening are very slim. So then what happens is the goal isn't to then cure HIV, it's to suppress the viral load. So, as we know, there's not currently a cure for HIV, but there are medications in combination that completely suppress that viral load down to undetectable. And then when doing that, it allows that CD4 count to recover. So when the viral load is undetectable because of that combination therapy of medication, the virus cannot be transmitted sexually. So that's sort of that. I don't know. It's called like a U equals U principle, and that's U like the letter U equals U principle, and it's undetectable equals untransmittable. And it's one of those, kind of reassuring evidence-based things that we tell our patient when we are providing education. So the entry and CCR5 inhibitors. So I'm going to try to move through the medication classes in sort of like, I guess, the order that they invade the cell. So the first step is infection. So the virus has to physically get inside the CD4 cell. And this class of medications, the entry and CCR5 inhibitors, they are supposed to stop that from happening. So they are trying to stop the virus from physically getting inside the CD4 cell. So the medication Infuvritide, that blocks the fusion process itself. It's like, jamming the virus from getting into its jamming that docking mechanism that the virus uses to get inside the cell. And then Malraviroc blocks a specific doorway. It's like the CCR5 co-receptor that some strains of HIV use to enter the cell. Now, notice that I said some strains. That's not like a throwaway detail. Don't pay attention that I did say some strains, because not every patient's virus uses like that same particular pathway to get inside of the cell. So tropism testing is usually required before that Maraviroc medication is started, and that is to confirm that the patient's virus is actually using that specific entry point. So skipping that test prior to starting that medication, and you might be giving a medication that has nothing to block because the virus isn't using that pathway to get inside. So both of these are reserved for like treatment experienced patients with multi-drug resistant HIV. These aren't typically first line drugs. They're what we reach for when other combinations have already failed. Okay, so moving right along. Once the virus is inside of the cell, its next job is then to convert its RNA into DNA using an enzyme called reverse transcriptase. So that's the whole reason HIV is called a retrovirus. So this class of medications blocks that conversion. But the two subtypes in this class, they basically block that conversion in different ways. So the NRTIs, which are the zidovirines, those are like fake DNA building blocks. So the enzyme grabs that fake piece and tries to keep building the DNA chain. But that's where the chain terminates right there when it grabs that fake DNA building block, because it's the medication and not actually, the building block that it thinks it is to continue that DNA chain build. And then you have the NNRTIs, and those are the delaverdines, and these don't incorporate into anything. They just physically dock onto the reverse transcriptase enzyme itself, but at a completely different spot. And it kind of jams it from working altogether. So it's a different strategy, but basically like the same outcome. So the virus can't finish converting its RNA to DNA. So the zyovidine has a different important thing to know about it. So it was the first medication ever proven to reduce the mother to child transmission of HIV. It was part of why this medication became like the backbone of basically like the art of the medication in the first place. So with the zidovudine, you want to watch for bone marrow suppression. And then you want to watch for a rash with the deluverdine because in rare cases that rash can progress to Stevens-Johnson syndrome. So when a patient is on an NNRTI, any new rash gets reported immediately. We don't tell them to just watch the rash and see if it spreads. Any new rash that they notice gets reported immediately. So the next step in the virus's life cycle, so once it has viral DNA, it has to insert that DNA into the host cell's own genome using an enzyme called integrase. So once that insertion happens, the infection essentially is permanent to that inside of that cell. So the viral DNA is now a part of the cell's own genetic material. So raltegravir blocks that insertion step. So it blocks it there, and the virus never gets to make itself a permanent, like, part of the cell. So this is often a preferred first-line medication, specifically because its side effect profile is comparatively mild. So mostly with like headache, GI upset, or insomnia, which matters a lot for a medication regimen for someone who's going to be on it for the rest of their life. So one thing worth flagging for this class is you want to separate dosing from aluminum or magnesium antacids. So those medications will significantly cut the absorption of this medication. So the last step of the viral life cycle that we will cover is even after the virus takes over the cell to make new viral proteins, those proteins come out as one long strand that has to be cut into functional pieces by an enzyme called protease. So blocking that cutting step, you get a non-functional viral particles that can't go infect new cells. Now, here's something that actually, it's one of the more sort of interesting pharmacology facts. The medication ritonavir is barely used anymore for its own antiviral effect at full dose. Instead, it's now used at a lower dose as like a booster for other protease inhibitors. So why would we use a drug for something that is like another main job of a drug? And it's because this medication, the ritonavir, it's an extremely potent inhibitor of the CYP3A4 enzyme, and that's the enzyme that metabolizes medications in the liver. So give a low dose of the ritonavir along with another protease inhibitor, and it slows down how fast the liver breaks down that other medication, which means that the other medication's level stays higher for longer, letting it lets it have to be dosed less often, less often. So it's a side effect of its own. It's a side effect of that ritonavir chemistry, and it being basically like repurposed on purpose. So that same CYP3A4 blocking superpower is almost like a double-edged sword. So it also means that the ritonavir has a large number of drug interactions, and it needs to be avoided with a lot of strains of other narrow margin medications. So we know that the narrow margin medications are the ones that can go from therapeutic to toxic very easily, just by a small fraction of, an increase in that medication. So if we're taking it with a medication that's already going to slow down the liver from metabolizing it, that's going to basically cause that narrow margin medication to flip to toxic easier. So basically, anytime you see a patient on ritonavir, a full medication review is not optional. It's essential. We want to make sure there are no other narrow margin medications also being administered. So the next section that we will move on to are the biologic response modifiers. And this is basically a shift in strategy altogether. So chemotherapy attacks the cell. HIV medications attack the virus. And now these medications don't attack anything directly. They work with the immune system, and they are essentially amplifying what it's already trying to do. So the interferons are substances your body already makes naturally. They're part of your normal antiviral and anti-tumor defense. So what we're doing here is giving them at pharmacological doses, which is way beyond what your body makes on its own. And so that's to amplify the natural effect on purpose. So the alpha interferons get used for things like hairy cell leukemia and hepatitis. And then beta interferons get used for more like multiple sclerosis to cut down on the frequency of relapses. So here's the adverse effect I want you to really anticipate because it's almost universal. And it's a flu-like syndrome. So fever, chills, muscle aches, especially with the first few doses. So if a patient doesn't know that this is coming, then they're going to think something has gone extremely wrong. So with this medication, we want to pre-medicate with Tylenol or with acetaminophen, and it's often dosed at bedtime to sort of help with some of the symptoms that it is going to produce. And then we make sure to tell them ahead of time that this is going to happen so that they don't think the medication isn't working and so that they remember to pre-medicate with the acetaminophen. And then one other thing to pay attention to is that some interferons carry a box warning for depression and suicidal ideation. So this is a medication where mood changes aren't just like an inconvenience to note. They need to be screened for actively and discussed every visit with this patient. So moving on to the colony stimulating factors. So the medication filgrastim brings us right back to that myelosuppression. Except now we're doing something about it. So the medication tells the bone marrow to crank out more neutrophils, specifically to shorten how long and how severe that chemo-induced neutropenia gets. So you avoid giving filgrastim within 24 hours before or after cytotoxic chemotherapy. And that is because filgrastim is trying to get the bone marrow cells to divide rapidly, and chemo is trying to kill rapidly dividing cells. So giving these medications too closely together, you're essentially handing the chemotherapy drug fresh, actively dividing bone marrow cells to destroy. So that's working directly against the reason you're giving the filgrastim in the first place. So with this medication, bone pain is extremely common as the bone marrow expands and ramps up its production. But that pain is usually manageable with a non-opioid analgesic. Um, and then it's rare, but it's serious. One condition of this medication is splenic rupture. It rarely happens, but it is something that can happen, and it's very severe. It's very serious to make sure to watch out for. So your patient may report severe left upper quadrant or shoulder pain. And if they do, so we don't just brush that off as, pain as a side effect from this medication, because that splenic rupture is serious. If your patient reports that severe left upper quadrant or shoulder pain, we report those right away. Okay, so moving into the interleukins. So the prototype medication, the aldelucan, it's a recombinant interleukin 2. So it's a substance your body makes naturally, but it's given at like a pharmacological dose to help rev up your T cells and natural killer cells against tumors, specifically in metastatic renal cell carcinoma and melanoma. So the adverse effect to really know here is capillary leak syndrome. And I want you to picture what that phrase actually means. So the capillaries throughout the body become abnormally permeable, and fluid leaks out of the vasculature into the tissue all at once. That gives you hypotension, edema, and pulmonary congestion simultaneously, because fluid is literally leaving the blood vessels where it belongs and pooling where it doesn't belong. So that's exactly why the aldelucan is given inpatient under close monitoring with daily weights and strict INO tracking. So you're watching for that fluid shift in real time, not finding out about it after the fact. And so then here's a mechanism-based contraindication that you need to understand versus just memorize. So this medication is avoided in organ transplant patients. So let's just kind of think about why. So you've given this medication to deliberately rev up the immune system's ability to attack. And in a transplant patient, that's precisely the immune activity you've been trying to suppress to protect the graft. So given that this medication, giving this medication is basically telling the immune system to reject that transplanted organ. Okay, so moving right along, we are now on to anti-rheumatic medications. So now in this section, the immune system is basically attacking itself. So in rheumatoid arthritis, the immune system has essentially turned on its own body. So it's attacking its own healthy tissues as if it were a threat. So this is sort of broken into two kind of classifications of like disease modifying anti-rheumatic drugs. So you have non-biologic and you have biologic disease modifying anti-rheumatic drugs or DMARDs. So with the non-biological DMARDs, this is where you will see methotrexate again. So we discussed methotrexate in the oncology section because in very large doses it's given to treat cancer. But now we're going to talk about it as a non-biologic DMARD. Um, so at low doses, this medication, the methotrexate, is used for rheumatoid arthritis. So it isn't trying to wipe out DNA synthesis in a tumor. When it's used as a non-biologic DMARD, it's calming down an overactive immune response and dialing back that inflammatory cytokine. So it has a totally different goal clinically. It's given in a dramatically lower dose, although it is the same molecule. And then you also have the hydroxychloroquine, and it's got an interesting back history also. So it started as an anti-malarial medication. And so it works by interfering with how the immune cells process antigens, which tones down the overall inflammatory response. So it's also used for lupus, which tells you something about how broad autoimmune calming can be with just one medication. Now, the single highest stake safety point in the entire lecture, and I mean that literally, so I want you to pay attention. Methotrexate for rheumatoid arthritis is dosed weekly, not daily. So this is a high alert medication precisely because of that dosing schedule. So real documented fatal medication errors have occurred when methotrexate got dosed like it was a typical daily pill instead of a weekly schedule that it actually requires. So if anything else, if everything else leaves your memory from this presentation, just remember methotrexate for rheumatoid arthritis is weekly, not daily. And so then just on the monitoring side, the hydroxychloroquine, that needs patients on that medication need routine eye exams because long-term use carries a retinopathy risk. And that's an easy one to forget because otherwise this medication seems or feels fairly benign. So the biologic DMARDs or the TNF inhibitors, so the etanercepts and the adalimumabs, those are TNF inhibitors. They neutralize tumor necrosis factor alpha, and that's a signaling molecule that drives a lot of the joint destruction in rheumatoid arthritis. So block that one signal and you slow down the damage significantly. So here's a mechanism to risk connection that I want you to actually reason through because it's a great example of why understanding mechanism it beats memorizing a list. So TNF isn't just involved in rheumatoid arthritis. It also plays a normal role in keeping latent tuberculosis contained, dormant, walled off from inside of the body. So when you block TNF broadly, you're not just calming joint inflammation, you're also potentially letting a dormant TB infection reactivate. So that's exactly why TB screening is required before starting any of these medications. And that's why it carries a black box warning for serious infection risk. Because so many patients on these medications self-inject at home. Injection technique teaching basically how to inject this medication is very important, and it's a practical piece of nursing care. So it's something that directly affects whether that medication actually gets delivered correctly week after week. Moving right along into the immunosuppressant medications. So this section is almost the mirror image of what we just covered. Instead of an immune system mistakenly attacking the body's own joints, here we are intentionally suppressing a perfectly healthy immune system on purpose so that it doesn't attack something and perceive it as foreign, like a transplanted organ. Um, so we will jump right into the calcineurin inhibitors. So these are like the cyclosporine and the tacrolimus medications. These are the backbone of most transplant anti-rejection regimens. So they block an enzyme called calcineurin, which T lymphocytes need in order to activate and start producing the interleukin 2, essentially cutting off the immune system's ability to organize an attack on the new organ. So these are narrow therapeutic index medications, which basically not enough and too much is a very small window. So that's why with these medications, routine trough blood level monitoring, it's not optional. It's required for this medication. You have to draw a trough before you can administer your next dose. So you're basically threading a needle between under suppressing, risking rejection, and over suppressing, which is risking toxicity and infection. So one interaction I promise your patients will actually ask you about by name is grapefruit juice. So it inhibits the same CYP3A4 pathway these medications rely on for metabolism. So drug levels can climb significantly with regular grapefruit consumption. It sounds almost too simple to be real, but I promise it is real. And it's a clinically significant interaction, and we make sure we educate our patients, but it's worth a very direct conversation at every medication reconciliation that happens. Okay, so continuing with our immunosuppressant medications, we have the anti-proliferative and mTOR inhibitor immunosuppressants. So this slide is going to complete the classic transplant triple therapy concept. So we will talk about why transplant regimens use 3 different medications at once instead of just like maxing out one medication. So azathioprine and mycophenolate, those block purine synthesis. And if you remember from earlier in the conversation when we were talking about anti-metabolites, when we were talking about cancer treatment, these are the medications that mimic like the molecules that are needed to synthesize the DNA within the cell. So if you have a medication that's going to block that purine synthesis, if you don't have purines, then you don't have new DNA. And so then there's no proliferating lymphocytes. And then sirolimus takes a completely different route. So that one blocks the mTOR pathway that T cells need to respond to that interleukin 2 signaling. So here's the actual logic of triple therapy. So the calcineurin inhibitor a corticosteroid, and then one of these anti-proliferative or mTOR medications, those three together each hit the immune response at a different point in the pathway. So lower doses of three different medications, each blocking a different step, causes less toxicity overall than trying to push one single medication hard enough to do that entire job by itself. So it's basically the pharmacologic equivalent of like building a fence with several shorter sections instead of like one impossibly tall wall. And then one clinically distinct detail worth knowing here is that sirolimus it impairs wound healing. So this is why like surgeons and dentists need a heads up before any procedure on a patient who is taking that medication. So that's a very concrete sort of practical piece of information that you make sure to include in the education when you're teaching your patients on this medication. It's not just like an arbitrary lab value that needs to be tracked. Patients on this medication will have impaired wound healing, so any type of surgical or dental procedure that is going to be done, that surgeon or that dentist needs to know about it ahead of time. Okay, so we will shift all together and move on to drug therapy to prevent disease. So everything up to this point has been reactive. We've been killing abnormal cells, fighting existing viruses, calming down the immune system that's, misbehaving and attacking itself, and then suppressing the immune system to protect organs that have been transplanted. So for this presentation, vaccines are the only proactive section that we will discuss today. And vaccines are given to perfectly healthy immune systems before the disease ever shows up to basically train it ahead of time. So for patients on many of the medications that we discussed today, the chemos, the biologics, the transplant immunosuppressants, those have like a specific vaccine safety consideration that we are going to talk about in this section. So there are several vaccine types that are listed, and rather than just kind of reading through all of them, just you want to be able to sort them into kind of two categories. Is it a live vaccine or is it not? So live attenuated vaccines are the MMRs, the varicella, and the rotavirus. These use a weakened but still living pathogen. They generally give you the strongest, longest lasting immunity of any vaccine type. But for that same reason, they are contraindicated in pregnancy and in significant immunosuppression. Because a weakened immune system may not be able to keep even a weakened pathogen in check. So everything else on this slide, inactivated subunit toxoid mRNA, so cannot cause the actual disease because there's no live pathogen involved at all. So that's why they're generally safe even in immunocompromised patients, though they often need like a booster dose to keep immunity strong over time. So here's my honest advice. Don't memorize 5 vaccine categories as 5 separate facts. Memorize one, and then like live versus live, and then sort everything else through it. That one filter is what you'll actually use at the bedside. So one more concept worth understanding rather than just memorizing is herd immunity. So when enough of a community is vaccinated, the pathogen struggles to find a new host to infect, which indirectly protects the people who medically cannot be vaccinated themselves. So like newborns, certain immunocompromised patients. So vaccinations itself, vaccination isn't just like an individual decision. It does have a community level effect as well. Okay, so the birth through 6 year vaccination. So this is the busiest vaccine slide of the whole presentation, and I just want to be upfront with you. Try not to memorize like the exact age by age schedule for this slide. Schedules get updated by public health authorities regularly, and by the time you're practicing, today's ages might have shifted. So what I want you to walk away with is like the pattern, not like the specific calendar. So look at which vaccines on the list are live: MMR, varicella, and rotavirus. And notice they're all clustered right there in early childhood. So that's not a coincidence. It's exactly why the live vaccine safety screening we just talked about matters so much at like well child visits. So every single one of those visits, you're asking, is this child significantly immunocompromised? Or is anyone in the household pregnant or immunocompromised? That question has to happen before those particular vaccines go into the arm, or in this case, sometimes in the mouth, such as the rotavirus is an oral vaccine. So combination products like a shot that covers the DTaP, the IPV, and Hib, those all at once. So those exist for a very practical reason. So cutting down how many separate injections a toddler has to sit through in one visit. It's a small mercy, but it's a real one, both for the child and whoever has to hold them down. So when you're looking at vaccination records, which, maybe you pay attention to, maybe you don't have to. But for like myself, as I'm approving clinical sites and doing those types of things, when you're looking at a vaccination record, you'll see that the DTaP, the IPV, the Hib, those are all listed in one category because those are a combination vaccine. So when the toddler gets that one vaccine, it's including all three of these together. So ages 7 through 18, adolescent is a different kind of vaccine visit than the early childhood visits. And this is much more of like a booster and catch up window than a first exposure window. So the immune system's already met most of these pathogens through an earlier series. And so now we're just kind of reinforcing and adding a few new ones like HPV. So speaking of HPV, here's a teaching point that's generally useful in a real conversation with a parent or a patient. So this vaccine works best when it's given before likely exposure. And this is exactly why it's recommended starting in the preteen years rather than waiting until later adolescence. So that timing logic is worth explaining out loud because why does my 9-year-old need this now is a question that you will get asked. And it's because we want to vaccinate before the patient or person or child is before they are likely exposed. So the practical nursing task in this age range is reviewing the full immunization record at every single visit because of catch-up scheduling. Filling in anything that may have been missed earlier comes up consistently here. So kids fall behind schedule for all kinds of reasons, and adolescent visits are often the moment to catch up on those. So this slide on the adult and older adult vaccines, this is where the whole lecture kind of comes full circle. So the zoster, pneumococcal, and RSV vaccines all target diseases that get more dangerous, specifically as people age. That's why they're age triggered rather than given to everyone at once. So assessing and offering these proactively at every visit matters because adult immunization rates run consistently lower than childhood rates. So nobody's tracking grown adult vaccine schedule for them the way that pediatrician's office tracks like the vaccination record of toddlers. And so the real connection back to everything we've spent talking about is think about who's sitting in front of you on the adult medicine or oncology floor. So you have patients on chemotherapy, biologic response modifiers, DMARDs, and transplant immunosuppressants we covered earlier today. These are the exact patients who both need the most careful screening before any live vaccine and are the most vulnerable to the very diseases these adult vaccines are designed to prevent. So immunosuppressed and in greater need of protection at the same time. So the immunosuppressed and in greater need of protection at the same time. So that tension is exactly why this assessment can't be skipped. So this slide is almost like a checklist to just keep in mind when we're going over vaccine safety and then nursing considerations. So before you give any vaccine, you're kind of assessing, asking yourself about these concepts. So you're screening for a severe allergic reaction to a prior dose of the vaccine or any components of the vaccine. So if your patient is allergic to eggs, maybe and eggs are a component of the vaccine, then you're not going to want to give this medication or this vaccine to your patient. We're keeping in mind live vaccine contraindications in pregnancy or immunosuppression. We're thinking about appropriate spacing between live vaccines given on a different day, and then whether the patient has a moderate to severe acute illness right now. And note that a mild cold is not a reason to withhold a vaccine, a detail that trips up a lot of people constantly. So on documentation, always give the vaccine information statement before administering. And we always document the date, the site, the route, the lot number, and manufacturer when we are vaccinating our patients. And that's not just busy work. Like several of these, like if there's ever a recall or an adverse event, we can track it all the way back. We know the lot number and the manufacturer. We know the date it was administered. We know the site it was administered in. So documenting that information and then having the patient hold on to that information is important documentation to keep track of. And then one other nuance worth understanding is the VAERS. It's the VAERS, and that's basically the reporting system for vaccine adverse events. It is a passive monitoring tool. So reporting an event there is not an admission that the vaccine caused it. It's simply just a surveillance system designed to catch patterns that, and that distinction matters when we're explaining to your patients, like, what to be worried about. So let's shift away from pharmacology altogether into math, into dosage calculation. So oncology dosing looks different from a lot of what you've calculated so far, because mainly many chemotherapy medications are dosed based on body surface area rather than just body weight. So we will get into that in the next slide. 3 formulas cover almost everything in this unit. So we'll just walk through each of those logically so that you understand the formula itself. So body surface area you will see as BSA dosing is the default for most cytotoxic chemotherapies. And BSA is used instead of just like weight-based because the BSA correlates better with a lot of the physiologic process. So like your blood volume, your organ size, and your metabolic rate. So those correlate better than just knowing the patient's body weight alone. So 2 patients can weigh the same, but have meaningfully different BSAs depending on their height. And for medications with a narrow safety margin like chemo, that difference actually does matter. So luckily, BSA itself is usually already calculated and in the chart based on your patient's height and weight. So your job then is just to apply it correctly when you're doing your dosage calculation. So weight-based dosing is simpler and shows up with a lot of biologics like filgrastim. It's dose per kilogram times the patient's weight. But the habit I want you to build here is always do a sanity check, your answer against like the stated maximum dose. So a calculation can be correct, but still be clinically wrong if it blows past like a safety ceiling. And then IV infusion rate is the one that you'll use once pharmacy has already prepared a bag with the total dose in it. So then you're just figuring out how fast that bag of medication needs to run. So the trap to watch for, if the original order was BSA based or weight based, you have to convert to a total dose first before you can calculate a rate. So skipping that conversion step and the calculation rate at that point is basically meaningless. So we will work through examples so that it makes more sense to you. So let's actually work these together instead of just looking at them. So grab a pen and follow along with me as I'm talking through the information on this slide. So cyclophosphamide is ordered at 600 milligrams per square meter, and the chart says that this patient's BSA is 1.8 square meters. So to set up the formula, ordered dose times BSA. So 600 times 1.8 gives you 1,080 milligrams as the total dose. Now, here's a habit I want you to build for life, not just for the assessment. So after you calculate, ask yourself if the number is reasonable. Does 1,080 milligrams sound like it's in the ballpark of a typical adult chemo dose? Yes? That kind of gut check catches a decimal point error before it ever reaches a patient. So the second example, weight-based this time. So filgrastim is ordered at 5 micrograms per kilogram per day for a patient who weighs 68 kilograms. And you have a vial on hand at 300 micrograms per milliliter. So the first step is to find the total dose. 5 times 68 gives you 340 micrograms. So step 2, convert that dose into a volume that you can actually draw up. So 340 divided by 300 comes out to 1.13, which rounds to 1.1 milliliters for the syringe. Now, that's a 2-step process every time with weight-based dosing when it's paired with a concentration. So get the total dose first, then convert to volume. Don't try to skip straight to volume. So let's combine both skills because in real practice, that's exactly how it's going to work. So you're rarely going to get handed a nice pre-calculated total dose without doing some of the work yourself. So cisplatin is ordered at 75 milligrams per square meter in a 250 milliliter bag to run over 2 hours for a patient with a BSA of 1.7 square meters. So first, the total dose. 75 times 1.7 equals 127.5 milligrams. Now, here's a subtlety that's worth noticing. Pharmacy has already prepared this exact amount in that 250 milliliter bag. So when you calculate it yourself at the bedside, you're not actually determining the dose from scratch. You are verifying that what arrived matches what was ordered. And that's a real life safety check. So then the rate, you have 250 milliliters divided by 2 hours gives you 125 milliliters per hour on the pump. So now it's your turn. So pause the recording right here and work through the next, the next question here, and then come back to the recording. So paclitaxel is ordered at 175 milligrams per square meter for a patient with a BSA of 1.6 square meters. What is the total dose to be prepared? So pause your recording right here, work this out yourself, and then start the recording again or press play to see if you got the correct answer. Okay, so using the same BSA formula, we take 175 times 1.6, and that gives you 280 milligrams. If that's what you got, then you've got this process down. Okay, so these are the key takeaways. And rather than reading, these bullet point by bullet point, I just want to leave you with, a handful of things that will actually stick with you. And then if you remember these, then the rest of the details can be basically like re-derived from what I'm going to tell you to hold on to. So first, almost every medication that we discussed today, it does one of two things. It either kills an abnormal cell or it turns the immune system up or down. So if you can categorize a medication that way, you already understand its likely effect profile. 2, myelosuppression is the thread running through nearly the entire cytotoxic side of oncology, which makes infection prevention and CBC monitoring a near universal nursing priority in these population of patients. 3, HIV is always treated in combination because the virus mutates too fast for any single medication to hold the line alone. 4, the DMARDs and the transplant immunosuppressants are both turning the immune system down, but for different reasons. So one is to protect joints from the body's own immune system, and the other is to protect a transplanted organ from it. And both come with real infection risks, but also a real trade-off as well. 5, vaccines are the one section today that's purely proactive. And the patients most in need of the protection they offer are often the same patients whom live vaccines are the most dangerous. So that tension is exactly why vaccine screening is never skipped. And then 6, Confident BSA-based, weight-based, and IV rate calculation isn't just a math exercise. So in this patient population, a dosing error carries real, serious consequences. So precision here is patient safety, not just a skill for exam or assessment purposes.